Hi, everyone. Welcome to tonight's event. I'll just give it a moment as everyone makes their way in. I hope everyone's doing well tonight. Here on the East Coast, it's a little chilly. Dr. Ganji, where are you from? I didn't
Hi.
even ask.
Yeah, so I'm in Pittsburgh, Pennsylvania.
Oh, so we're getting the same cold weather. So, well, I will kick it off. Welcome to tonight's Woo You event, Keratoconus Diagnosis and Management with Dr. Vishal Janji. I'm your host, Dr. Jennifer Stewart. And thank you to Glaucos for providing an educational grant for tonight's event. Just some reminders for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll also display a QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks and ask questions throughout the presentation using the Zoom on-screen floating panels. Here's where they are on your phone. Oh no, we don't have your bio. Oh no. I might have you introduce yourself. Can you just share a little bit about yourself, Dr. Janji, while we have you?
Sure. Yeah, no worries. I saw that page earlier, but I thought you're gonna ask me, which I'm glad you did. So, my name is Vishal Janji. I'm a cornea specialist. I work at the University of Pittsburgh. Actually, I have dual appointment. I work at UPMC, and I'm also a professor at the University of Pittsburgh School of Medicine. I specialize in corneal and external eye diseases. My main areas of focus and research are actually keratoconus, dry eyes, and infectious keratitis. Um, I am the division chief for cornea services in my department. There are six of us here, and we run a very busy cornea practice. We look after a big region in Western Pennsylvania, and very happy to be here. Thanks for inviting me.
Well, we're happy to have you here. And no financial disclosures, and they've all been mitigated. So with that, I'm going to turn it over to you. I will see you at the end for the Q&A, and we can't wait to hear what you have to say.
Thank you. I'm going to share my screen here. Just confirming, can everybody see my slides?
Yes, I can see him.
Okay. All right. Okay, I'm going to start now. So, in the next 50 minutes exactly, I would say, I'm going to talk about a very important disease, keratoconus, which is actually a form of corneal ectasia. When you talk about corneal ectasias, keratoconus actually comes on the top. It's the most common form of primary corneal ectasia. The word kerato means cornea. Conus is the shape, which is the cone, as shown in a picture here, which is from an actual patient. You can see when you look at it from the side, impressive corneal thinning, and the cornea is actually bulging out. I don't have any financial disclosures relevant to this topic, this talk. So keratoconus is characterized by axial, which is central or paracentral stromal thinning. There's actually enough evidence showing that there is epithelial thinning as well, but we mainly focus on the stromal thinning because that's what leads to the shape of cornea in keratoconus. Patients will present with progressive irregular astigmatism. This is one of the most common presentations. Don't be surprised if you see patients with extreme myopia and very little astigmatism in keratoconus. Excuse me. The estimated prevalence of the disease is very variable, and the fault lies with what how we've published the data in the past 30 years or so. If you pick up the data in the United States compared to the Far East, compared to the Middle East, compared to South America, there's a wide variation. So the estimated prevalence is anywhere between 0.05% to 5%. Usually it presents in the second decade of life. Sorry, you have to excuse my throat. But it's important to remember, and we'll discuss that more as we go ahead in this presentation. The age of presentation is actually becoming less and less. We see more young patients nowadays. And that is attributed, one, to the awareness of the disease in general. Second, also to the highly advanced technologies for corneal imaging that we use to screen these patients. And we'll discuss about those in detail. So in normal cornea, the corneal stroma is made up of parallel collagen fibers. They are really stacked nicely. It's amazing if you look at the pictures of crystallography from the corneal tissue, how the collagen is stacked upon, the sheets are stacked upon each other. There are bridges or cross links between these collagen fibers. In keratoconus, it has been shown that there's reduction in number of these collagen links, there's degradation of the fibers, the sheets, the displacement of sheets, and rearrangement of collagen fibers as well. So the clinical presentation is, as I mentioned earlier, progressive impairment of vision, irregular myopic astigmatism. You can see Fleischer ring, also known as due to epithelial iron deposits. In advanced cases, you can see corneal scarring. In very advanced cases, when the cone continues to progress, there might be a tear in decimates. And again, we'll discuss separately about this, causing a condition of cloudy cornea called acute corneal hydrops. Early signs are basically due to the stretching of the cornea. As you can imagine, if there is too much stress because of the stretch, you can see these folds known as Vort striae. One of the early signs is also, as I mentioned earlier, the epithelial iron line called the Fleischer's ring. Now, it is important and interesting to realize that the Fleischer's ring actually marks the base of the cone. So if you switch on the cobalt blue filter on your slit lamp, you can actually see the Fleischer ring. Picture is actually when the blue light is on. Once you see the Fleischer's ring, you can estimate the position of the cone. You can also estimate the shape, the size of the cone to a certain extent. When keratoconus becomes advanced, you can see, as I showed in one of the first slides, really massive cone. When patients look down, the cone actually presses on the lower lid and causing this sign called Munson sign. If you shine a light in an advanced cone, from one side you will see there is total internal reflection and you see a Rizzuti sign. And of course, one of the late signs is corneal scarring, which can be due to excessive rubbing, or it can also be due to healing of acute corneal hydrops. Excuse me. How do you diagnose keratoconus? So those of us who are senior on this call, on this presentation, they would probably remember in late 90s, early 2000, we had a machine called VKG, video keratography, basically a very, I would say, sort of advanced version of a placido disc, showing how the interior surface of the cornea has a cone, which is an inferior cone. That is why everything is pushed in this picture inferiorly. But if you look at it carefully, as compared to a placido disc, the only advantage that VKG gave was it actually gave us the corneal power and the K values, which was very important at that point. So gradually, people moved on from VKG to slightly more advanced machine, which was actually very popular in sort of between 2001 and 2010 approximately, called OBSCAN, which was a slit scanning device. It provided more accurate data on corneal elevation. So the advent of OBSCAN actually was very important because this is the first time people started talking about posterior corneal elevation in keratoconus, which was later on found to be one of the earliest signs of keratoconus. So OBSCAN actually enjoyed a great deal of popularity, especially in subspecialty clinics, to diagnose early keratoconus. The problem with OBSCAN was that the repeatability of the device was really terrible, especially in abnormal corneas, which means that if you image a keratoconic cornea and then you image the same patient a few hours later, you might get different readings. So eventually, everybody moved on to Scheimpflug imaging. The most commonly used Scheimpflug imaging device in the United States is still Pentacam. It has got one Scheimpflug camera. There are devices available in the US and outside of the US which have got two Scheimpflug cameras. There are devices that will have two Scheimpflug camera and also placido disc image based scanning. So Scheimpflug imaging, basically, this was a paradigm shift in terms of how we image cornea. The posterior cornea became more important with Scheimpflug imaging. There were very important papers published in late 2000, close to 2010, 2012, showing that as compared to OBSCAN, the repeatability of Scheimpflug imaging was excellent. This is a picture showing a typical position of the cone and also the pattern of thinning. You can see top left, basically an early bow tie. You can have an asymmetric bow tie, a displaced paracentral cone, an inferior cone, which is one of the most commonly seen clinical scenarios in real life. You can have a patient with a different kind of corneal ectasia called pellucid marginal degeneration. We're not going to discuss that, but briefly speaking, in pellucid, the area of thinning is between 4 and 8 o'clock in the inferior quadrant. And you can have a central cone as well, which is actually very commonly seen in patients with keratoconus. But the question is, are we diagnosing keratoconus early enough? Let's look at this picture. Many of you might not have seen this device or used this device. This is a swept source OCT called Kasia. It was recently approved by FDA. It's made by a company called Tomei, no financial interest, based in Japan. So you basically look at different maps, interior elevation, posterior elevation, refractive power, exit power, and pachymetry device, and the K values as well. There's an inbuilt program in the swept source OCT, like many of the devices now, that tells you the chances of this OCT being similar to another patient's OCT that has keratoconus. So as you can see, the ectasia screening program tells us that there's almost a 0% chance that this patient has keratoconus. So you're confident this is the left eye of a patient. But sorry, the pentacam of this same patient shows the D score of 0.42, which basically tells us that this is a normal cornea. But if you look at the other eye of the same patient, you see advanced keratoconus. This is the swept source OCT showing that there's a 95% chance that this patient has keratoconus. And of course, the keratoconus is advanced enough for us to figure that out even clinically. And the pentacam shows skewed values to one side, advanced D score showing keratoconus. So basically, this eye, the right eye, has got full-blown keratoconus, whereas the left eye is normal eye, at least normal on corneal tomography, normal on OCT, thereby telling us that this is a case of form first keratoconus, or as Renato Ambrosio will say, very asymmetric ectasia, VAE. Always remember that corneal ectasia is a bilateral event. So there's a huge possibility that there is a big discrepancy between the right eye and the left eye. Another patient, right eye, you can see pentacam looks normal. Left eye, you will see the pentacam is abnormal. So clearly, another example of a patient which who has keratoconus. So clearly, we are not diagnosing keratoconus early enough. So this is a very nice editorial which was published about 10 years ago in the British Journal of Ophthalmology, showing that we still need better devices to pick up keratoconus at an early stage. So, sorry. Uh, Non-tomographic diagnosis is one of the things many people have been working on, including our team, and I'll discuss about that briefly. So you can have access to wavefront aberrometry. It does allow you to pick up keratoconus at an early stage. Some people have access to corneal biomechanics. You can use FTIR, which is clearly not available as of today in clinical practice, or you can use an optical quality analysis system, which was very popular about 10 years ago, but it sort of went out of practice. I want to spend some time on corneal biomechanics, which is going to be not only is a hot topic, but it's going to be very relevant in the next few years. So while we know that evaluation of corneal shape and optical properties has been applied widely in the diagnosis of keratoconus, as we saw in those pictures, understanding the biomechanics actually elucidates the pathophysiology of keratoconus. Um, Always remember what we see on corneal tomography is a structural change. The idea of change in corneal biomechanics is that we are trying to understand, all of us, is there a change in the biomechanics of the cornea which happens before the structural change will happen, which can be picked on corneal tomography. So that's the whole concept of understanding the biomechanics. So the biomechanics can be theoretically measured by ultrasound, MRI, Brion scattering, which is, it is available already in the United States, but not that popular. Optical response analyzer, which is ORA, commonly used by glaucoma specialists, and also Corvus ST. Of all these devices, the most studied device so far is devices so far, ORA and Corvus. Um, Corvus is an ultra high speed Scheimpflug camera which captures the corneal deformation response uh, to a puff of air. It just works like an NCT machine, a non-contact tonometry. So once you look at the corneal deformation response, you can actually have objective parameters to look at the change in corneal biomechanics. This is an actual picture when the puff of air hits the cornea, it bends the cornea in. So this is the CDR, corneal deformation response, and the cornea springs back, which is, and then you can measure the outward corneal applanation. So we've shown in the past that corneal deformation response actually is different in normalized compared to keratoconus eyes. There are multiple other groups that have shown the same thing. If you have access to Corvus, you can actually get an objective index called the Corvus Biomechanical Index, which is a result of an inbuilt AI program. It uses random forest plot technology to come up with one device, one index called the CBI, Corvus Biomechanical Index. Any CBI number more than zero point 0.5 is supposed to be suspicious for keratoconus. So the technology went one step ahead and actually combined the D score from Pentacam and the CBI from Corvus, giving us another objective index called TBI, or tomographical biomechanical index. This is all theoretical for now, but hopefully this would be available in the United States in the next few years. Excuse me. So going back to the first example that we looked at, this is an OCT of a patient that was supposed to be normal based on the ectasia screening program. Also, the Pentacam, the D score was normal. And if you look at the Corvus biomechanical index, it's actually more than zero point 0.5, thereby showing that there's a possibility that biomechanically, even the normal eye or the normal looking eye of that patient has abnormal Corvus biomechanical index, and thereby it's suspicious that this patient might develop keratoconus in future, and the TBI was abnormal as well. So the conclusion of this part is that it's important to diagnose early disease, form first disease. There are devices such as Pentacam, OCT, ectasia screening programs, and biomechanical devices that measure biomechanical properties of the cornea for refractive surgery screening. Sorry. Sorry. And it is also important for proper selection of cases for collagen cross-linking and to evaluate the efficacy of different treatment modalities. Now let's go towards the management of keratoconus. So glasses, contact lenses, intracorneal ring segments, corneal transplantation. These are all well-established modalities to manage keratoconus patients, and we've used these for more than 50 years now. The fundamental problem in these treatment modalities is that they all improve vision, but they do not alter the course of the disease. If you see a patient with keratoconus who had a small transplant done about 15 years ago, you will see ectasia beyond the graft host junction, which is not uncommon. And contact lenses really work well for that. But that also tells you that we took care of the central 6, 7, 8 millimeter cornea, but beyond that boundary, the keratoconus is still there in the remaining host cornea, which continues to progress as the patient ages. This is a nomogram that we published about 15 years ago, basically showing that if the corneas are of certain thickness or are less than certain thickness, you can do different kinds of keratoplasty, whether that is partial thickness transplant or full thickness transplant. Uh, I I'm always very happy to present the slide because none of this makes any sense now. So basically, if you have a cornea that has got keratoconus, you really don't have to jump into doing a corneal transplant straight away. So the new goals of management are halt the progression of the disease and then visually rehabilitate these patients using medically necessary contact lenses. When it comes to halting the disease, collagen cross-linking clearly has become the most important surgery for keratoconus patients, not only in the United States, but worldwide. This is a graph from an actual paper, shows, again, talking about corneal biomechanics. With collagen cross-linking, there is a shift in the biomechanical properties from a sort of a weak level to a normal, stable level. So that's what collagen cross-linking does to a cornea that has got keratoconus or ectasia. Very important to remember, and certainly a point that I never ignore. In the eye bank data, EBA data shows this or corroborates with this. There is a reduction in the number of corneal transplants that we do for keratoconus patients with the advent of cross-linking. There are studies mainly from the UK and Europe showing that how cross-linking is a very cost-effective measure compared to a big surgery such as corneal transplantation. We all understand that very well now. One of the first randomized controlled trials of collagen cross-linking, basically showing that there is a significant reduction in Kmax values and a significant improvement in uncorrected visual acuity compared to controls when you do collagen cross-linking for progressive keratoconus 3 years later. Over the years, this is just a very brief summary, and there are multiple studies, more than 100 studies now, some with 10-year follow-ups, showing that there is a significant reduction in Kmax values. There may or may not be a change in uncorrected visual acuity, but there is a definite change in best corrected visual acuity once you do collagen cross-linking for progressive keratoconus. Of course, the Dresden Protocol, the conventional cross-linking that is supposed to slow down or stop the progression of keratoconus. The major disadvantage of the procedure is the length of the procedure. So we basically remove the corneal epithelium, soak the cornea for 30 minutes with riboflavin, and after that, irradiate the cornea with UV light. There's a blue lamp for 30 minutes as well. Conventional cross-linking can be associated with slow visual recovery, pain, and sometimes the risk of corneal infection. So there are protocols that were described to do epithelium on cross-linking, also called transepithelial cross-linking. Of course, there's less pain, less discomfort. The original protocol also recommended that we do cross-linking in patients where the corneas are 400 microns or more than that. But there are plenty of protocols out there that enable us to perform cross-linking in thin corneas. Excuse me. You can also use a high fluence or accelerated cross-linking, which will lead to reduction in surgical time, but there are questions about the efficacy of such protocols. And of course, you can combine surface ablation in very, very early non-progressive ectasias along with cross-linking. So I'll mention this again, but as of today, well, as of last week, only conventional cross-linking was approved in the United States by the US FDA. Just last week, a new form of cross-linking procedure was approved It's called epi-on cross-linking or epi-oxa cross-linking. Basically, that's a trade name using a specific form of riboflavin that leaves the epithelium on and enables us to perform cross-linking at a different fluence, thereby reducing the time of surgical procedure. Multiple studies have shown that the predictors of success of cross-linking are high K value. This is from the Melbourne trial, younger age, and also central cone. Cross-linking in corneas with very steep Ks. In general, since 2009, there was one study published that if you do cross-linking in corneas that have high Kmax, which is more than 58, that is a risk for treatment failure. However, after that, there are multiple studies showing that it does not matter how steep the corneal cone is, as long as there's no scarring, as long as the corneal thickness is adequate, close to 400 microns, you will get very good results even if you perform cross-linking in advanced keratoconus. We showed about 10 years ago that if you perform cross-linking, high fluence cross-linking in corneas that are really steep, specifically more than 58 diopters, you will see massive amount of flattening and the patient's uncorrected visual acuity will improve as well. This is an example of a patient who had a spherical equivalent of 3.25 preoperatively and a best corrected visual acuity of 20/40. The K steep values of 50.4. A year down the line, the patient's SEQ improved to 0.75, BCVA was 20/20, and there was a diopter and a half of flattening seen in K values. Another patient, you can see advanced keratoconus, excuse me, the steep Ks are 59.1, BCVA is 20/100. A year down the line, the BCVA improved to 20/70. The steep K reduced to 55 at zero point 0.1 diopter. So exactly 4 diopters of flattening, which will enable better uncorrected visual acuity and better contact lens fitting in such patients. Another patient, 1 year follow-up, advanced cone. If you can read this, the central readings are close to 70, 71 diopter, and a year down the line, they're down to about 64.9 diopters, so about 5 diopters. So let's go back again to a few variations in cross-linking. One of the most important variation is using high fluence. So it's good to remember that the conventional cross-linking involves the use of UV light for 30 minutes, which is delivered at 3 milliwatt per centimeter square. So the total energy comes out to be 5.4 joules per centimeter square. So there is a law which many of you might have heard, a Bunsen-Roscoe law, uh, which basically says that as long as the total amount of energy, joules per centimeter square, is same delivered to the cornea, you can play around with the time for which the energy is delivered. And basically, you can reduce it to 5 minutes by increasing the power to 18, or you can reduce it to 3 minutes by increasing the power to 30. There are a few studies that have shown that if once you cross 9 or 10 milliwatt per centimeter square, the efficacy of collagen cross-linking actually goes down. And I'll tell you in a minute why that is important and relevant as of today. Just for those of you who are thinking if conventional and high fluence cross-linking have been compared, this study again published about 10 years ago, showing that although there's no significant statistically significant difference, but if you see the change in Kmax is about 1.6 diopters a year down the line compared to only zero point 0.5 diopters. So high fluence cross-linking still works. It still causes flattening. It still reduces or stops the rate of progression of keratoconus, but not as much as conventional cross-linking. So that's important to remember. Um, as I mentioned, transepithelial cross-linking is supposed to be less painful because you're not removing the epithelium. Visual recovery is quick. You still use a contact lens as you would do if you take off the epithelium. It was supposed to be sort of relevant, useful in pediatric age group where you want to reduce the pain. You don't want to keep a contact lens for too long. Of course, you want to reduce the risk of keratitis as well. There are Some studies questioning the penetration of riboflavin through an intact epithelium. And so many formulations of riboflavin, or they use BAC, benzene chloride, or you can use tetracaine, BAC, EDTA before doing cross-linking so that you cause these micro abrasions on the epithelium so that riboflavin and UV light can go through. This is, as I was saying, an animalized study done many years ago showing that we don't know how much is needed for an effective clinical effect a result, but there is histological evidence that the treatment depth is less with transepithelial cross-linking compared to conventional cross-linking due to the presence of epithelium in such patients. Again, as in conventional cross-linking, multiple studies have shown that the transepithelial cross-linking actually is useful in certain cases, but the results overall are variable. So you can see if you focus on the Kmax, there's a flattening of three diopters, but there's also a case series where there's no flattening, or there's actually some steep corneal steepening after transepithelial cross-linking. This is a similar study showing the efficacy of transepithelial cross-linking in advanced keratoconus. Again, if you are looking at K values or Kmax values of more than 50 at more than 60 diopters, you will see a mean decrease in Kmax is 1.63 diopters about a year down the line, even with transepithelial cross-linking. So this is really, as of last week, I'm going to spend some time on this. This treatment, Epioxa, was just approved last week or less than 2 weeks ago. So, over the past 15 years, we have known that during collagen cross-linking, there is a massive utilization of oxygen surrounding the cornea. That's how actually the type 1, type 2 reactions they happen in during cross-linking. So you can see as the UV light is switched on, the concentration of oxygen really goes down. So which basically tells us that the efficacy of cross-linking is going to reduce. Well, let me say this, which tells us that the amount of cross-linking that is happening is really less, probably less than what we need. So there has been, the proposition has been to increase the amount of oxygen in the corneal stroma. And this is cumulative wisdom for, multiple scientists, researchers over the past 10, 15 years. People figured a way out to produce, no, to keep the oxygen concentration at a higher level close to the cornea. So the device that was approved about 2 weeks ago by the FDA is called Epioxa. What the device does is that you still use a special riboflavin. You don't have to use remove the epithelium, so it's a transepithelial technique. The riboflavin contains BAC, so you will still see adequate absorption of riboflavin into the corneal stroma. And you use these special goggles. You can see this tube that is going into one side of these goggles, and the tube is connected to an oxygen tank. So while the cross-linking is happening, you are providing extra oxygen to the region surrounding the cornea, so collagen cross-linking keeps on happening. Excuse me. I actually adopted this from Epioxa. So you can see there's a oxygen tank that has to be set up. And once you do that, there's a protocol that you have to follow. You instill Epioxa every minute for 4 minutes. And then you do every 30 seconds for 6 minutes. And you rinse the cornea and measure to ensure that adequate thickness is now 325 microns, not 400 microns, which means you will be able to do more patients that are otherwise not suitable for conventional cross-linking. Then you use the boost goggles. This is the name for those goggles, the commercial name, to increase the oxygen supply. You start at 1 liter per minute oxygen flow, And after 2 minutes, verify that there is 90% oxygen concentration within the goggles. And the basically the company provides you, sorry, with all the necessary instrumentation. This is the machine which looks quite similar to the machine that is right now available from the same company. You basically align the device and irradiate the eye for 11 minutes and 6 seconds, as compared to 30 minutes with the previous device. And at the end of the treatment, you basically measure oxygen concentration within the boost goggles and turn off the oxygen flow, remove the boost goggles and speculum, and then you can apply your post treatment eye drops. Um, so I can tell you from my own personal experience, you still have to use a bandage contact lens in many patients because after you do all this, the epithelium will be still a bit swollen. If you send the patient back home, they will still feel a lot of pain because the epithelium is really not smooth. But the epithelium, the contact lens doesn't have to stay on the eye for a week, as we do in collagen conventional cross-linking. So this is a procedure that everybody's hoping is going to be a real game changer in terms of providing cross-linking to our patients. This is a slide going back to the biomechanics. So on Corvus, we have the advanced software, and I just wanted everybody to take a look at how pre and post collagen cross-linking corneas are more resistant, are different in terms of resistance to that puff of air that bends the cornea. And I don't have to tell you which cornea, which color is post cross-linking. You see the difference? So it's the same patient's cornea. They're superimposed on each other. As you can see, once the puff of air hits the cornea, before cross-linking, the corneal deformation response, CDR, if you remember, I mentioned that it's more in sort of in corneas that are not being cross-linked. So just a visual representation of what collagen cross-linking does to the cornea. Combination treatments, I know I mentioned this. You can combine surface ablation such as PRK with cross-linking. Unfortunately, there are a limited number of studies with very short follow-up time period. Right now, the protocols need to be standardized if you're going to offer our patients combination treatments. So to conclude this part, collagen cross-linking is definitely recommended for progressive keratoconus with corneal thickness is more than 400 microns. This is going to change now. Uh, Very soon, hopefully, and results show modest improvement in corneal tomography and also in visual acuity. There is currently no evidence to suggest that cross-linking is useful if keratoconus is stable. So the last part, keratoplasty or corneal transplantation. So, well, I did not go into the detail of what corneal transplantation is, but let me just say you see a cornea with scar, try and fit it with contact lens. If contact lens fitting is not possible, if the patient is not happy with contact lenses, if contact lenses are not available, the next step is corneal transplantation. It can be of two kinds: partial thickness, where you remove just the stroma, the epithelium, the endothelium can stay on, excuse me, and the full thickness of penetrating keratoplasty, where you remove all 5 layers. As far as possible, we try and perform partial thickness or lamellar transplant in patients with keratoconus because we know once you remove the endothelium, the chances of endothelial graft rejection are as high as 15 to 20%. Graft survival is more in lamellar transplants. It's an extraocular procedure. You'd never go inside the eye. Need for post-op steroids is less. Post-op care is easier. Even if you lose your patient to follow-up visit or they miss a few follow-ups, they're going to be fine. So we still do penetrating keratoplasty in patients that have dense scars. So in corneas, as shown on the picture on the top, there's no way that you're going to help the patient if you do a partial thickness transplant because the scar is dense and also it's full thickness. Um, so we try and do, as I said, deep interior lamellar keratoplasty. The idea is to use a big bubble technique where you basically bare the descemetes, remove all the stroma, and then you sew the graft using 10 nylon stitches Typically use 16 to 20 stitches in these patients. You can get down there various multiple iterations how to do this surgery. Everyone has a different technique. This is a technique that we published again many years ago. You can use a diamond knife because it's guarded and graded, so you know how deep you're going. So you measure the corneal thickness at different points at the corneal periphery. If your cornea is about 350 microns, you can set your diamond blade to 250 microns, make an incision. Now you know that you're 250 microns deep. Then you excise the top 250 microns, leaving about 100 microns in keratoconus patients. So this is how the patient, sorry, this is how the patient will look like after the surgery. You can do an OCT showing the thickness of the cornea. So basically, hold on. Sorry. I'm sorry, my phone was ringing. So, in patients, and I told you I wanted to discuss this separately. In patients where the keratoconus is very advanced, there can be a break in the Descemet's membrane. And if there's a break in Descemet's membrane, the aqueous is going to seep into the corneal stroma, causing corneal edema. This is called acute corneal hydrops. As you can see, a clear cornea in keratoconus becomes cloudy suddenly, causing a lot of pain, inflammation, and reduction in vision. So acute corneal hydrops is probably one of the few semi-emergent conditions in keratoconus. This is an example of a patient who had bilateral keratoconus, 22-year-old male, young patient, had his right eye cross-linking done, left eye was waiting for cross-linking, and he kept on waiting. And he came back with sudden decrease in vision. You can see in OCT there are fluids of pockets of fluid. This is basically aqueous going seeping through that break in the Descemet's membrane into the corneal stroma, causing corneal edema. Of course, as I said, this is a really painful condition causing sudden drop in vision. So the patient waited for 2 more weeks, came back again. As you can see, the eye drops worsen. Look at these pockets, they're sort of coalescing together. At this point, we gave an option to the patient that we can inject air into the anterior chamber and thereby closing this gap, this break in the descemet and sort of leading to early resolution. Patient opted to wait at that point. So in 4 weeks' time, as you can see, the eye drops had increased massively. It almost looks like a cornea or a mass within the cornea. This is all fluid. And this time it was very difficult for us to find space or clear area to inject air. And we just had to wait, excuse me, for the eye drops to resolve, which it does actually. So 8 weeks later, the patient was looking like this. So this case presentation basically shows the natural history of progression in corneal eye drops. If you wait long enough, the eye drops, the break is going to close, and the fluid is going to resolve itself, causing scarring. One of the bystander effects in corneal eye drops is when it heals, the scarring causes flattening of the cornea and it actually improves the vision sometimes, and also fading of the contact lens is sometimes, but it's better. So this is nature's way of sort of flattening the cone, if I can say that. This is another patient who had post LASIK corneal ectasia. This was her first presentation. She presented with corneal eye drops. The patient refused any surgical management, and we waited. And as you can see, about 2 months later, the corneal eye drops resolved completely. There was actually focal flattening in the area, which was very steep. So the patient's vision was very good. With a contact lens, this patient sees 20/20 now. You can inject intracameral gas or air. Air is very straightforward, less complications. If you want long-term sort of impact, you can use 20% SF6 or 14% C3F8, the isoexpansile gases. These are less commonly used nowadays, mostly when we have to um, use any intracameral gas, it's air. This is an example of a patient with high drops who had air injection and resolved rather quickly. You can also, with the advent of introp OCT, you can actually use OCT to tap out some of the fluid from the top that can lead to early resolution in patients who have acute corneal hydrops. This is a technique that we rarely use in patients who have really recalcitrant, long-standing eye drops, because if you leave the eye drops for too long, the risk of corneal neovascularization increases. Now, that eye drops is going to scar down, but the presence of corneal neovascularization will actually lead to poor graft survival, because most of these patients are, once the hydrops is resolved, they will have very dense scarring, and that dense scarring will need PK. The outcomes of PK, the prognosis in keratoconus is really good, but in a cornea that is vascularized, you're basically jeopardizing the integrity, not the integrity, the outcomes of the graft. The long-term survival is going to be less. So this is my final slide, the overall conclusions of the talk so far. I hope everybody understands or understood that early diagnosis of keratoconus is very important, especially now with the advent of collagen cross-linking. You need to provide timely treatment to the patient to avoid corneal transplantation for reasons of avoiding a surgery that has long-term implications, needs follow-up. And these patients, they do really well with contact lens fitting. As I showed in my slides, even if a patient has an advanced cone, you can perform collagen cross-linking and visually rehabilitate the patient really well. For those of you, sorry, for those of you who do contact lens fitting, I'm sure you've seen wonderful results of medically necessary contact lens fitting in patients even with advanced cones. In terms of diagnosis, corneal tomography is still the most commonly performed imaging in patients with corneal ectasia, and it actually works very well. It picks up more than 90-95% of patients. But as we try to improve our understanding about the diagnosis of keratoconus, early keratoconus, I think corneal biomechanics definitely has a role in enhancing the diagnostics. More importantly, technologies such as corneal biomechanics or the new and upcoming Bruin microscopy, they help us understand the pathophysiology of keratoconus. Um, Collagen cross-linking is one of the most promising treatments. It's not as invasive as a transplant. The recovery is very quick, and it needs to be offered to patients, all patients with progressive keratoconus. With the new device that has been approved just 2 weeks ago, we are hoping that we will be able to uh, um, sort of avoid more corneal transplantations and offer collagen cross-linking to more patients who have keratoconus. In a minute, despite all this, you might still have to perform a corneal transplantation. And as I mentioned in my talk towards the end of my slide, whenever possible, we do a partial thickness transplantation, because one of the main reasons is that it basically avoids the risk of endothelial graft rejection, thereby enhancing the longevity of the graft. Some of these grafts can last for as long as 50 years if done in a nice way. So I want to thank all my collaborators from the United States and also from other parts of the world. It really literally takes a village to do all that research. And sort of, as I mentioned, this is the collective wisdom of all these people that I work with, that I was able to compile this presentation. And I hope I've tried to sort of provide as much as information as I could on this topic. I'm happy to take any questions. Thank you very much for your attention.
Thank you, and your voice did hold. I know you've been struggling a little bit with laryngitis, so you made it.
Thank you. Sorry about that. Yeah.
That's no, keep drinking your hot tea. Thank you so much for that wonderful presentation. Let me see. We did have a number of questions come in, so let me just look through those. What is the ideal patient age for cross-linking?
There is no ideal age. We so we have a children's hospital attached to our own university. The youngest would be probably less than 10. When you see progressive disease, especially in kids, we don't even see progression now. We don't even wait for the progression now. I just saw a 14-year-old last week, and we spoke with the parents. We told them that if they want to, they can wait. But if a patient has been diagnosed at the age of 14, the possibility is that he or she is going to progress. So in kids in pediatric age group, we offer cross-linking pretty much as soon as the diagnosis is made. And this is actually, it's a very relevant question because when I look at Epioxa, the new treatment that has been approved by the FDA, they don't even need to document progression for the new guidelines. But let's go back to the question that you asked. So again, I want to reiterate, there is no age limit for performing cross-linking. Now, it works both ways. If you see a patient with post-LASIK ectasia who's still progressing at the age of 58, for example, you still offer cross-linking.
Yes. Let me see. Why is there more incidence of keratoconus in dry climates?
So, one thing that I did not discuss in my talk, excuse me, is the risk of eye rubbing and the association of eye rubbing and keratoconus. So there's no good answer to the question. It's a great question though. I wish somebody had an answer. So far, allergies, eye rubbing, which are more commonly seen in the Far East and in tropical weather, they can be associated with a high risk of keratoconus. So if I have to answer this question very briefly, I would say likely due to eye rubbing in hot weather, in tropics, and also that can be associated with a high incidence of allergic conjunctivitis, specifically VKC, vernal keratoconjunctivitis. And there are multiple studies out there showing increased prevalence of corneal ectasia in patients who have VKC.
Perfect. What is the recovery like for a patient who has corneal cross-linking?
Recovery is very fast. So with the conventional cross-linking, where we remove the epithelium, we put a contact lens, patients are usually back to work once the contact lens is off. Sometimes we ask them uh, not to go to like stay away from work, but I'm told by the patients when they come back for a week, one follow-up, that because they felt fine, they started doing online work or work from home if they can do that on day 3 or day 4. Basically, the discomfort only lasts until the epithelium is open. Once the epithelium is closed, which really happens in a patient, in a young, healthy patient, in about 48 hours or sometimes 72 hours, which is 3 days, patients feel very comfortable.
See, there's more coming in. Let's see. Why do you still need a bandage contact lens with epi on cross-linking?
Yeah, so I did mention epi on cross-linking. You still expose the cornea to a lot of eye drops. Some of the new riboflavin will have BAC, and the cornea is still exposed to the air for, let's say, 11 minutes to 30 minutes, depending on what machine you're going to use. So the epithelium does become rough and sometimes a little swollen as well. So if you don't give these patients a bandage contact lens, they will feel the discomfort. There are patients, so I haven't done an epi on in many years because it was not FDA approved. I used to perform epi on when I used to work outside of the United States. And most of the patients, they will need a bandage contact lens at least for 24 hours, if not for 3 days. But yes, they certainly don't need a bandage contact lens for a full week, which is usually the case when you perform conventional cross-linking.
Looks like we have time for a few more. How would you treat eye drops topically?
So topical treatment of eye drops is, certainly do not use steroids. You don't need steroids. If you use steroids, you're putting the patient at risk for an infection. If you really have to use steroids because of a lot of inflammation, you must cover with a topical antibiotic or an antibiotic cream, erythromycin, polymyxin, depending on where you practice, what is available. You can use moxifloxacin eye drops. Uh, so the things that certainly will help too, one is hypertonic saline. That can be in form of eye drops, muro or muro ointment. It reduces the swelling. And to reduce the pain, you can use some cyclopentolate 1% 2 or 3 times a day. So that reduces the pain to a certain extent. There is some evidence that you could reduce the pressure. You can give oral acetazolamide, Diamox, but the evidence is not really robust. So we usually use muro ointment and cyclopentolate. We don't use steroids just because if the patient is lost to follow-up, sometimes they'll come back with infection.
Perfect. It looks like we have time for one last question. With air injection for acute eye drops, is the patient required to be on their back during the treatment period?
Yeah, that's a very smart question. Yes, yes, that makes sense. So if you're injecting air, you want the patient to lie down on their back at least for the first 24 hours or so, as much as possible. Um, the tamponade, so the T half-life of air is 24 hours, which means if you put a air bubble which is 8 millimeters in diameter, in 24 hours, you can expect that air bubble to be about 4 millimeters, roughly speaking. Now, fortunately, most of the breaks in eye drops are central or paracentral, which means even if you leave a small bubble, but the patient is on is on his or her back, the bubble is still going to tamponade that break on the decimates. So it is advisable, in fact, use more useful for this procedure to be successful. The chances are higher if the patient is on his or her back.